We'll open it up for some QA from the listeners. Those of you who want to send in a question, please email them to priya@trilix.com, or you can also post the questions on the page that you're listening to this talk now in the comment section. Dr. Grupp, we have received quite a few questions via email and some on the page as well, so I will quickly go through them. I will read them out so that you can answer as best possible. Phil wants to know, will CAR T-cell therapy be considered for frontline treatment?
Oh, I love that question. So right now, the FDA-approved therapy is available for patients who either chemotherapy doesn't work at all, which is called refractory, or where the disease has actually come back not just once but twice, so 2 relapses. And we love the idea of being able to use this treatment earlier and save kids a lot of intensive chemotherapy. And so the Children's Oncology Group, which is the National Clinical Trials Group for Cancer in the United States, is starting a protocol this year that's going to pick patients very early in their treatment who have not experienced a relapse, but who we know have characteristics that say this is really bad ALL, bad leukemia, and we're going to try CAR T-cells within a few months of diagnosis in these patients. And so that's pretty upfront, and it'll be a while before we have an answer on that clinical trial, but we're starting that research right now.
Thank you, Doctor. The next question is from Amy. She wants to know, what happens if the cancer cells mutate to not express the antigen anymore that the T cells are targeted towards? Would the therapy then lose its function?
Yes, so it does. So the answer that's what I was talking about before. That the thing that the T cell see is a particular target called CD19. If CD19 goes away, which leukemia sometimes does, then you need an alternative target, and we have developed an alternative target, and that's one of the things that the Whitehead Foundation is helping us with. So that is our limitation. That is the thing that I believe is keeping us from an 80% success rate long term. Short term, we're over 90%, but the parents aren't coming to us for short term. They're coming to us for long term, and the way to get to long term 80% is to have that second target. So I think your Amy's question is spot on.
Yeah. Thank you, Doctor. So I think we answered the question on whether a booster dose would be given if patients relapse. But we have a question from Nick, who asks, what about children who have not relapsed? Would they need to take a booster dose sometime in future to maintain their cancer-free state?
Yes. So if the patient has their disease come back, but it is still CD19 positive, which is to say it still has the target, we could use these cells to get them back into remission, and we have. But the question that's being asked here is really about a true booster situation. So we have a well patient with no leukemia that we can detect, but a fear that the leukemia might come back because the T cells have disappeared. And we, even though that's a small minority of our patients, we have absolutely done the booster approach. And it's hard to say whether it works or not, right? Because you're not actually treating leukemia that you can see, but it certainly is something that has not caused any harm.
Yeah. Thank you, Doctor. Kenny wants to know, is there an advisory board of researchers which will help guide a patient cancer support group to which immunotherapy platform is best matched with their particular tumor etiology? For example, CAR T therapy versus ACT versus CRISPR.
That's a tough question. The trouble is that there's so much innovation going on in the field right now that the usual benchmarks that we use as docs is long-term disease control, and for that to happen, you need to have been doing it for a number of years. I mean, we're 6 years out from the first patient we ever treated. That's pretty early in some ways. And so the reality is that picking the right therapy when there are 5 different options is a challenge, and that's where your oncologist, I think, is a great help. And then, as Tom mentioned, Carrie doing her research on this and also seeing what makes sense from a clinical trial perspective. All of these new therapies are available at largely at large medical centers and on clinical trials. And so this is a real opportunity for families of children or for adults with cancer to say, hey, I'm willing to try something that's new. I want to see if there is some possibility for better outcomes, and the way I'm going to access that is a clinical trial. But there's no magic formula for 3 or 4 competing therapies that are very early in their development, because we don't have that comparative data.
Thank you, Doctor. We have a question coming from Australia. Katie writes, our 1-year-old child has ALL, MLL, and had a cord blood transplant recently. If she relapses, can you provide CAR-T treatment for her? We noted that your trial is for 3-year-old children only due to the limited availability of expanded T cells in younger children. What CAR-T options do you have for younger infants like our daughter?
Well, what I'll start off by saying is that I hope that this particular patient stays in remission forever. And nothing I would say is intended to provide medical advice for an individual patient, because, of course, I don't know any of the details. But I can answer the question in a general way. And I would say 2 things about that. First off, it is absolutely true that patients who are 2 years and younger, we have a lot more difficult time making CAR T cells from those patients than we do for patients who are older. And really what ends up happening, there's been a lot of work done on this at CHOP, and Dr. Barrett is really leading this research. And what we've learned is that the very intensive chemotherapy that babies get for ALL really messes with their T cells. And even though the T cells grow back and are present in the patient's body at reasonable numbers, they don't work right. And this is very much an issue for babies. Now, in a patient, this is where it gets kind of complicated and interesting. When a patient has undergone a bone marrow transplant, then they don't have the baby T cells anymore. They have T cells that have never received chemotherapy. And in that situation, we're perfectly capable of making a CAR T cell product in a patient in that situation. But of course, the hope is that the transplant is successful and there's no need for CAR T cell therapy. The patient just remains in remission. That's what we all hope for.
Thank you, Doctor. We have a question from an anonymous person who writes in, any recent advances in the use of CAR-T for T-cell lymphomas?
That is a really challenging question. So what I would say about that, so all the diseases we've been talking about using CAR T-cell therapy for is leukemia or lymphoma that's of B-cell origin. And now the question is about leukemia or lymphoma that is of T-cell origin. And so here's this odd circumstance that we're in. We have CAR T-cells, which are made from your own normal T-cells, and we have a cancer which is derived from T-cells. And the problem is without some very fancy genetic manipulation, which we're trying to figure out right now, there's no good way to keep the CAR T-cells from killing each other, because they're also T cells at the same time that they're trying to kill the cancer. And so that problem of the CAR T cells killing each other because they're using a T cell tag is a challenge in the field right now. T cells, leukemia and lymphoma, when it relapses, is very hard to treat. I've had a wonderful parent who has been pushing for many years for us to make the kind of advances in T-cell therapy that we've made in B-cell directed therapy, and I think that there's hope for this in the future. But there's some targets that we think that may not kill the CAR T cells at the same time that we kill the cancer T cells. But it is a challenge in terms of getting the T cells not to recognize each other.
Thank you, Dr. Grupp. Neil writes in, can you share your perspective, please, on the CAR-T program at Novartis versus the program at Glaxo and Legend Pharmaceutical? Any other players in this space that you could highlight for us? For full disclosure, the product that I have
or the CAR T-cell approach that I have been working personally to investigate for the past decade is the one that was licensed to Novartis, which is called Kymriah. The other major product that's available right now is that Yescarta product. The difference between the two is that one tends to last longer, which is the one that we've been working with, Kymriah, and one tends to go away very quickly, which is the Yescarta product. Now, in leukemia patients, there is a clear advantage to keeping the cells longer, so I think it's really important. In lymphoma patients, it may be that just having these cells for 6 to 8 to 10 weeks may be long enough, and there may not be as obvious a difference. So it's a little bit hard to tell the answer to that right now. And so I think the platforms differ, the diseases differ, and the applicability differs. And then, of course, I have the most experience with the product that lasts the longest. Now, there are lots of other companies. I just want to jump in and say one more thing. And there are lots of other companies that are developing a whole group of different approaches. And so the answer to this question is in 2 years is going to be completely different, I think.
Thank you, Dr. Grupp. We have one last question from Mike, and this is on multiple myeloma. How is this therapy being conducted to address multiple myeloma? Are they targeting BCMA, CD38, or CD19, or a combination of these targets, or all of them?
So a lot of all of that. So I'm a pediatrician. I don't treat patients with myeloma, but I have been very excited by the results that I've seen with a specific target, which is the first one mentioned by that person, which is BCMA. And BCMA is a great target for myeloma, and we're definitely seeing significant short-term results in patients with bad myeloma with BCMA. And so we don't have enough follow-up to say if these are long-lived responses. We just doesn't mean that I don't think they are. It just means we haven't followed the patients long enough because it's brand new. But for me, as a researcher in the CAR T-cell field, to see something other than CD19 working this well is incredibly exciting. CD38 is being approached by a drug, but it's also being approached by CAR T-cells, and I bet in the next year or two we're going to see some data on CD38. I don't want to I could get super technical about this. CD19 shouldn't work in myeloma because of the way that myeloma works, but it does occasionally work, and when it works amazingly well, but it would probably work in a very small minority of cases. So for me right now, the most interesting shot on goal in myeloma, which is a disease where there are a lot of therapeutic options but no cures at all, is really the BCMA CAR.
Thank you, Dr. Grupp. We have a comment that has just come in on our page, and this is for you and the team at CHOP. The parent says, thank you, Dr. Grupp and the team at CHOP. Our daughter is 3 months post-CAR-T at CHOP and thriving. Our family is so grateful to all of you.
Well, thank you very much for that, and it's our fondest hope for each of our patients that those responses just go on.
Dr. Grupp, this has been a great discussion. CAR T-cell therapy is a breakthrough treatment for cancer, and thank you so much for your time and sharing all this information with us. We're almost at the end of an hour, and thank you for all the great work that you're doing, saving so many lives. Tom, thank you so much. Wishing Emily and your family the very best. Gary and Jack, thanks for the great questions. Also want to thank University of Pennsylvania and Children's Hospital of Philadelphia and the wonderful audience. This talk will be made available on CureTalks.com. Please visit our website for details on upcoming talks. Thank you, everyone. Have a great evening.
Thank you very much.
Thank you very much. Thank you very much for giving us a new last chance.